Welcome to the Critical Care Obstetrics podcast. I'm Dr. Stephanie Martin, Medical Director at Clinical Concepts in Obstetrics, and I'm here with my partner, Julie Arafay, our Simulation Director at Clinical Concepts. And we're going to be doing a very interesting case review today. But before we get started, we want to remind you about a few ways that you can learn with us beyond the podcast. At our academy, you'll find a full library of online courses that we've built, designed to build your confidence and skills in managing high-risk and critically ill obstetric women. And we also encourage you to join us at patreon.com/CCOB. And that's where your support really helps us continue our mission. We encourage you to join us. We have live Q&As, exclusive videos, and we want you to be able to interact more directly with us. And we have a lot of deeper teaching pearls. If you want to watch us, we're on YouTube now. Just search for the Critical Care Obstetrics podcast. And now on to the podcast. So, Julie, let's get into this case. Are you excited?
Yes. This is one of my favorite topics. Not that it's a good topic, but I just feel like anything that we can talk about can help people better manage the case.
Yeah. Should we tell them what the topics are going to be?
Sure.
So in this one, we're going to see a pregnant patient who has respiratory compromise and ultimately develops cardiac arrest and requires a resuscitative cesarean. So we're going to be talking about the management issues there and a lot of the team performance and, preparation and planning and quality concerns from our perspective using this case as an example. So let's dive right in. We've got a 40-year-old multiparous patient, 32 weeks, who shows up at her OB's office with several days of shortness of breath and cough. She is a smoker. She is obese with a body mass index of 32. She does have a history of asthma. She's also chronically hypertensive, but is not on medication. And the OB appropriately sends her directly to the emergency department where she goes. And that afternoon in the emergency department, her blood pressure is 163/90. Respirations are 20. She's tachycardic with a pulse of 122. Her SATs are 98% on room air, and she's afebrile. On exam, she's got Ralls at the bases. They do a white count. It's normal at 10.8. There's no differential. She has a normal platelet count. Her hemoglobin is 11.1. And on her basic metabolic panel, she's got a potassium of 2.8, creatinine is 0.4, and her BNP is normal. So they admit her to the hospital, and there's a conversation about where to put this patient. So let's talk about that. Let's just start there.
Yes.
So this is a patient who clearly has some sort of respiratory issue. Even though her SATs are normal, she's tachycardic, but she's short of breath with a very high risk history. So differential in my mind, right off the bat. I mean, preeclampsia, just right there. She's severely hypertensive. She's tachycardic. She's got shortness of breath complaints. And she's got a history of asthma. So it could be pulmonary edema, cardiogenic or non-cardiogenic. It could be asthma. And then the other two things on our differential are pulmonary embolism and pneumonia. I mean, it's one of those four things, right? And frankly, she could have any of those things at this point. We don't really know. So she needs more workup. But we're going to admit her to the hospital to figure out, which I agree with. Where would you want her admitted? How do you have that conversation?
Well, if it were me personally, I would want her in labor and delivery because number one, she's preeclamptic, that is one of the contending diagnoses, which I don't think other units are going to be very comfortable with. No one outside of OB is comfortable with preeclampsia. So whether it's an antepartum unit or labor and delivery unit, whatever works best. But the thing that really strikes me is you need a process in your hospital for what to do when you have someone coming in who has medical complications and is pregnant and maybe potentially is not emergently going to deliver. There needs to be some criteria for who goes into what unit in the hospital when they're pregnant. And I think you'll see as this case unfolds, had they had a process or at least a thoughtful way to determine the best unit for this patient, things might have been different. It's hard to know, but you'll see
Yeah.
as the case goes on.
Yeah, and, I will say that preeclampsia or chronic hypertension exacerbation were never considered in the differential on this patient. So she continues to be severely hypertensive. Nothing is ever done about it, whether it's preeclampsia or not. We don't know if it's preeclampsia because no proteinuria assessment was done. She didn't have HELP syndrome, but we don't know if she had preeclampsia on top of her chronic hypertension or not.
Well,
So,
I think the other thing, sorry, that we have to keep in mind is that the blood pressure of like 160 over 90 is absolutely nothing in the ED. They
yeah.
think absolutely nothing of that blood pressure. So unless they have had clear instruction or they have clear parameters about what's normal and not normal for a pregnant patient, that blood pressure is not going to alert them at all.
Yeah, that's a really good point. There's different thresholds of concern regarding hypertensive response times in the ED compared to in labor and delivery. And obviously, in our world, this patient is severely hypertensive and requires evaluation and treatment. And in the ED, there's just a different sense of urgency around that. But, a few hours later, before she actually gets admitted to the floor, she's still in the ED and they do a chest x ray. She's still severely hypertensive 70s over 70s, which is interesting in and of itself. That suggests a volume issue because her systolic is disproportionately elevated compared to her diastolic. That's very much of a very wide pulse pressure of almost 100. So that
Yes.
suggests a volume issue. So on my list, just based on the very little information we have, I would put cardiogenic pulmonary edema at the top, as well as asthma exacerbation, pneumonia, and I put PE probably lower, but she is a smoker, she is obese, and she is pregnant. So we've got so many risk factors here. But
Right.
she is tachycardic, and her temp now is 99.5, and her O2 sats are 95%. Chest X-ray shows densities in both lungs, which may represent, I love this, trash bag diagnosis, fluid overload, HF, or pneumonia. All of the above, right?
Yeah. Yeah.
So which one is it? Well, you can't necessarily tell from an x-ray, right? But it could be pneumonia, it could be cardiogenic pulmonary edema. Um, we don't like to say heart failure, but basically pneumonia, cardiogenic pulmonary edema, which is not an unusual description on an x-ray in a pregnant patient. So she does get admitted to a med surge floor with a pneumonia diagnosis. Now, I will say that one of the things that was driving their decision is there were no beds in labor and delivery. Now, they're 3 floors away, these units. So we've got med surge, and then we've got labor and delivery, and there were no beds in labor and delivery. So in your unit, I want everybody to be thinking about, and then I want Julie, you to comment, like, there's no beds in L&D. You want this patient on labor and delivery. What are you doing? What do you do with her?
Yeah. I mean, do you put her in I have worked in units before where they would put a patient like this in the recovery room, wherever they
Mm-hmm.
would recover from the OB OR. Um, every unit is so different. It's hard to know what's going to be the better unit to go in. But I like the idea, even though it's not a very comfortable location, of being in the recovery room because you have a lot of equipment there and you have access to a lot of people, and they can come and respond whenever they need. Of course, that's a little
Mm-hmm.
bit of knowing what's going to happen in this case. But you could also potentially, if there's room, put this patient on postpartum as you know, a temporary location until you can get the patient into labor and delivery. All of those things I think need to be taken into consideration.
Yeah, and I would encourage everybody listening to start when you're trying to make these decisions, because there's so many differences and nuances from unit to unit. Start with, what are the needs of your patient? So this patient
Yes.
is going to need respiratory support potentially. She's going to need basic medical care. She's going to need frequent assessments in case she deteriorates. She needs, additional monitoring and evaluation for preeclampsia. She might need to be delivered. She's going to need fetal monitoring. Like, there's a lot of things that this patient has the potential to need. And then you decide, okay, here's her needs. Where are these needs best met? And that may not be your hospital. So this
Well,
is the
that's
first
true too.
opportunity to think about whether or not this patient should be admitted to the facility that she presented herself to, because that may not be the best place for her if you can't meet her needs right now.
Hmm.
It doesn't mean she
Well,
can't have her baby there later, but
right.
you might not be able to meet her needs safely.
The other thing I think I learned very clearly when I was a clinical nurse specialist in a level 4 hospital for obstetrics is that anytime a pregnant patient is off of labor and delivery, the NICU needs to be notified so that they
Mm-hmm.
understand there is a baby somewhere out there that is not in OB. And you need to have emergency supplies that go with that patient because I had a situation where an unanticipated delivery occurred. There was absolutely not one neonatal ambu bag anywhere to resuscitate this baby because no one had thought to take the supplies with the patient. So anytime, that's what I mean by process. Whatever you're going to decide is going to be best. Obviously, it has to be what's best for the patient and what's going to meet the needs of the patient. But that whole process checklist, okay, this patient's going to another unit. That means the NICU needs to be notified. That means emergency supplies need to go with that patient. And very likely, a nurse from labor and delivery is going to need to go and do some basic assessments on a regular basis at
Yes.
minimum to
Well, and
to
like
care
just
for this
fetal
patient.
assessment, just the
Yeah,
fetal evaluation. So this patient's been in the emergency room all this time, by the way, and there's been no fetal assessment. There's been no documentation of fetal heart tones. There's been no non-stress testing. There's been no fetal assessment the whole time this patient's in the emergency department. Now we're going to admit her to a medicine unit because we don't have room on L&D. Well, what would have happened on labor and delivery? Likely she would have been put on continuous monitoring because that's what we do, right? So they would put her on continuous monitoring and then determine whether or not to take her off. None of that happened. That's not acceptable. You can't have two standards of care in your facility. What are the patient's needs? And then where are you going to meet those needs? So she gets
exactly.
admitted. She gets admitted overnight, still no fetal assessment. And the next morning, her blood pressures are 150s over 80s. Her pulse is improved from the 120s to 100s. Her respiratory rate is 20. Her oxygen sats are 98% on supposedly on room air. She is wheezing, but says she's feeling better. They've started replacing her potassium. She's now up to 3.1. And then a few hours later, so early that afternoon, she starts requiring supplemental oxygen, 3 liters nasal cannula. And orders are written for antibiotics, which had not been started, and this patient admitted for pneumonia. An albuterol nebulizer routinely every 4 hours. She is asthmatic and has now developed hypoxemia. There were no orders for continuous pulse oximetry or assessments of pulse ox, and there's very few of those. And the physician orders an NST to be done every shift. Thoughts so far?
Well, I think having an increasing oxygen requirement is always an indication for increased nursing surveillance. So taking careful respiratory rates and not, counting with your stethoscope for a full minute is warranted in a patient like this. Making sure that you are doing a thorough assessment of breath sounds. And quite honestly, I have seen many preeclamptic patients come in, go to the admitted to the hospital, placed on bed rest, and they will normalize for a bit of time because you have changed their hemodynamics. You've improved their cardiac output by putting them in bed. It doesn't last. And I think
Mm-hmm.
we're going to see that could potentially happen. But I think you need to be aware of that. If you're if you're looking at these patients and you're like, oh, wow, why is this patient in the hospital? Because now her blood pressure's fine, her sats are good, her heart rate's down. Just wait. Because if she truly has the disease, that's not going to continue.
Yes, agree. Now I'm the physician, okay, and I've written an order for an NSTQ shift, but I've made rounds and I realize I should be saying, what's the status of this 32-week baby and this patient who's severely hypertensive and hypoxemic, and nothing is, I don't see anything. So I can just write the order NSTQ shift, and the nurses who are on the unit have no idea what that language even means. So they don't even know what it is that's being ordered, and they may or may not feel comfortable asking the question. As the physician, I could have communicated that need, but still the nurses taking care of these patients are not the ones who are going to be performing that test. So this falls on the nursing leadership to make sure that they know about the patient who's off the unit, which presumably they did because we know that L&D is full. So there's been some conversations about coming to L&D. So somebody in L&D knew, and there's a plan in place to do assessments of this baby in some way. So as the physician, I should be talking to my nursing partners and saying, has somebody done an NST and I just can't find it? When is can you come up and at least document fetal heart tones until somebody can come up and do an NST? Like, no fetal assessment has taken place at all in this patient. Now, she was in the OB's office the day of admission, where they presumably would have documented fetal heart tones, but they didn't do an NST. So we don't have really any fetal assessment. We don't know if the baby's alive or dead at this point.
This is a typical situation of this patient has fallen through the cracks.
Yeah.
And I'll guarantee you, labor and delivery was probably busy and
Mm-hmm.
full. And the charge nurse on that shift may have heard that there was a patient going to another unit. But if there's no process in place, did that communication get transferred to another nurse? And the nurses on the med surg floor, if somebody orders a test, what's the first thing you do? You look to order that test in the system. Is there a way to order an NST
Mm-hmm.
in your hospital? And if not, what are they going to do? Med surg units are notoriously busy and notoriously understaffed. So
Mm-hmm.
you just see this Swiss cheese model lining up. All the holes are lining up,
Yes.
and this patient is falling right through the cracks.
Yep. So the day goes by. So the patient's been on oxygen all day long, and at that evening, around 8 o'clock, the respiratory therapist who's been coming by to perform the scheduled albuterols every 4 hours comes in and to do their treatment. And prior to the nebulizer treatment, they typically perform a peak flow assessment. So for those of you who are not familiar with a peak flow assessment, it's a very simple device where you have to exhale very forcefully into this little handheld little meter that measures how well you're moving air essentially. So this is a very commonly done in asthmatic patients, outpatient on their own, just to understand how their asthma baselines are and how they're responding to their treatment and how severe an episode is. So you do it before the respiratory treatment, you do it after, and it's an objective measure of how much more air is being moved. But the RT documents in the chart that the patient can't do the peak flow, can't do it. Basically can't muster the strength to exhale forcefully into this meter. Okay. But doesn't inform anybody that the patient can't perform the peak flow, just does the treatment. Okay. That night, or within a half an hour, 45 minutes later, the nurse says the plan was to bring the patient to labor and delivery for an NST. So it's now evening, and the patient still has not had any fetal assessment done. And their solution for performing NSTs is to bring the patient to labor and delivery for an NST. I don't know why they didn't have a portable monitor, or maybe they chose not to use a portable monitor. Maybe it was in use elsewhere. Maybe they had an ICU patient being monitored. I don't know. But their plan was to bring her to L&D. Not terribly efficient, right? But they can't bring her to L&D because she's so short of breath. So the doctor says, okay, fine, just do the NST on the floor there. A very strange system. So clearly there's some access issues in this hospital. Makes me wonder if they don't do a lot of deliveries there or something. I don't know, but it's a very strange kind of system where, but anyway, she's too short of breath to come to labor and delivery for an NST. Red flag, red
That's
flag,
just
red flag.
remarkable. I mean, if someone can't get in a bed and be pushed in a gurney to another unit, wouldn't that, I mean, where are the criteria for even a rapid response? I
Yes,
mean, if someone can't breathe, that's an essential function.
yes.
You
And
would think that
you can't chalk this up to pregnancy.
no, no, but when you think about the respiratory therapist, if they're not familiar with pregnancy at all, they may think, well, look at that big belly there. Of course she can't do her peak flow. I mean, it may not trigger an
Mhm.
alarm. And again, that's that whole it's all about process. It's like it doesn't matter why the patient, you let someone know they can't do their peak flow,
Yes, exactly.
especially an asthmatic.
Yes. So this patient, she can't be moved to labor and delivery because she's so short of breath. We don't have vital signs at this time. So the nursing assessment is completely missing at this point, but she does document that she stayed with the patient to keep her calm, quote, calm and comfortable. So
But
there's
didn't
that.
assess the patient.
Correct. And there's
She's
that hint
patting the
about
patient, but not assessing the patient.
comforting her into respiratory failure.
Yes.
Um, I mean, to me, that's the first clue of anxiety. They didn't use the word anxiety, but the nurse felt the need to document that she stayed with the patient to keep her calm and comfortable. That to me tells me that this patient is extremely anxious. Then, very shortly after, there's documentation that she called the OB to report that the patient is agitated and fighting with her husband and requests, guess what? We
Because we got to
must have a
treat the anxiety.
benzodiazepine. Okay,
Oh,
everybody. Patient is anxious. She's anxious because she can't breathe. What is the treatment for that? Hint, it's not Ativan. Okay? Not okay.
yeah. Yeah.
Now,
At the very least, because she's pregnant, I can guarantee you any anesthesiologist would want to see this patient because she's pregnant, she's having trouble breathing, she's anxious. Any nurse out there, I am giving you permission to call anesthesia to come and see this patient and at least evaluate their airway so they know what they're dealing with.
yeah, and what surprises me about many things in this case, but especially this point here, this patient is on a med surge floor. They're more used to seeing patients with decompensating respiratory status than many L&D nurses. So I would have expected more response. And I'm wondering how much the pregnancy played a role in their minimizing of this patient's symptoms. I don't know, but there's just completely inadequate assessment being done here. And we're treating anxiety without in a patient who is visibly respiratory compromised, and we're not doing any respiratory assessments. We're not doing basic vital sign assessments.
Well, a patient with a supposed diagnosis of pneumonia.
Yes, that's
I
what they're
mean,
treating her for. They've got her on
putting
antibiotics.
yeah, putting everything together, if you have a pneumonia patient who's becoming anxious, wouldn't you think it would be due to oxygen delivery? That would be my first thought. There's
Yeah.
some problems with oxygen delivery here.
Talk about normalizing the abnormal.
Yeah. Yeah.
So within a few minutes, I don't know how this actually happened, but the nurse calls the internal medicine hospitalist, so not the OB hospitalist, the internal medicine hospitalist, and the hospitalist gives orders for a stat ABG. Totally appropriate. Okay. But before the hospitalist or the OB could make it to the bedside, the patient is essentially found in a kneeling position with a nurse assistant. So like the med tech that's on the unit, the patient's like essentially collapsed at the side of the chair in the room, and 3 staff members were unable to lift the patient. Okay, so here we are. We got a patient with respiratory compromise who's pregnant, who can't get up. She's collapsed, can't get into a chair. and 3 staff members can't help her into a chair. Okay, the patient has obesity, but her BMI is 32. This is not a patient who I'm imagining, is truly not able to be assisted, assuming that the patient has some agency herself. Major red flag. So what would you do at this point?
Yeah, I mean, the first thing that I learned back in the days when we gave terbutaline to everyone and we saw rampant pulmonary edema is the pulmonary edema posture, which is bent over, rocking
Mhm.
back and forth, trying to get air into their lungs. At this point, I'm going to call rapid response. I don't think I would call a code yet, but I'm definitely going to be calling the obstetrician, calling for a rapid response team, because I can guarantee you, once this patient gets in bed, if she's bent over like this trying to breathe, she's not going to be happy in bed at all.
Mhm. Well, they called security. They called the
Okay.
security guard to help assist the patient to bed safely, quote, since patient is pregnant, end quote. So they didn't call a rapid response, but they did, within a few minutes, they called a rapid response because she stopped responding. She stopped
Okay.
talking to them. So then finally, had to get to the point where the patient was unconscious and they call a rapid response. They did document that the pulse was present and palpable. I mean, okay, present and palpable. The rapid response team arrives 7 minutes later, and on arrival, the ICU nurse calls a code.
Mm.
No pulse. Okay.
I
The
I just I
OB.
just wanna
Mhm,
point out really
mhm,
quickly, it took 7 minutes for the rapid
mhm.
response team to come. This underscores my point that labor and delivery units need to be ready to handle the stabilization portion before help is gonna come. Not every
Yes.
hospital is gonna take that long, but it's reality.
Yeah. They might be in the middle of something else. They might be
Absolutely.
evaluating another patient. I mean,
Yeah,
they might have to go up several elevators. They might be they're going to be coming from multiple different directions. It's not like they're sitting in a room waiting to be called all together with a code card. That's not how it works. Yeah, it's going to take a few minutes for the rapid response team to arrive. And it did. So the OB and the hospitalist are essentially on their way together, and arrive at the same time because they both hear the rapid response overhead. And the OB is reporting to the rapid response, or is receiving a report from the nurse and the RT that the patient was getting the nebulizer and was able to talk, had been walking, and suddenly collapsed. So this is what was described. And the ICU nurse who arrived says that basically, as soon as she arrived, she looked for respirations and a pulse. Patient had none, and they immediately started CPR. So, sometime in the 7 minutes from the witnessed collapse to the rapid response team arriving, there was no respirations and there was no pulse. So, this makes me concerned that perhaps she had been down for even, I doubt she coded on arrival with the RRT. It's possible, but I'm wondering what kind of assessment is being done, or is just everybody paralyzed waiting for help to arrive, which definitely happens. And so they immediately called a code at that point. And okay, so we did code. We've got a code in a 32-week pregnant patient in a med surge floor on the floor. I mean,
not
we're
ideal.
laughing only because, not because this is funny, but because
No.
it's so absurd that these situations are even encountered, but they are. And the lack of action is almost predictable. The mistakes that are going to be made become so predictable that we shake our heads at this because we see it so consistently.
Yes. Yes. I I think this is one of those reminders to anyone who is listening to this podcast who has any control over what happens when you are going to put a pregnant patient on another unit. They need to be somewhat familiar with pregnancy, or they need to have warning criteria. I cannot tell you enough. If you have criteria for calling an RRT, or if you don't, even besides that, if you're going to have a pregnant patient on another unit, you need to have criteria when the OB team gets called. And it's not when the patient is in full arrest. I think that's pretty obvious to everyone. So if you are going to do this, you have to put some safety guardrails in place, and there has to be knowledge of what these are on the unit, even if you're doing it shift to shift, saying, listen, we've got this patient, we can't put her in labor and delivery, but these are your parameters. If this happens, then this. That has to be done. That has to be done if you've got a patient on another unit.
Yeah. And, so basically we've got a cardiac arrest of a 32-week pregnant patient in a hospital. But there's, this could have been on labor and delivery. This could have been in, med surge. It could have been in the ICU. It could have been in anywhere in the hospital. You have to be prepared. And the same thing needs to happen no matter where the patient is located. And that includes all the basics of everything that's going to happen with ACLS. You've got to get on the chest. You've got to get an airway. You've got to get a rhythm. You got to give them epi, and you've got to be ready for a cesarean. All of these things have to happen. And there are other things. You got to get the backboard on. You got to get the pads on, which means that's how you get the rhythm. But basically, all these things have to happen no matter whether the patient's pregnant or not, no matter where she's located.
Exactly. Exactly. And that type of response, I think it's difficult outside of the intensive care unit or a higher level unit. They don't experience nurses in labor and delivery, and I would say most med surg units, maybe not all, they don't run codes that often. That's why the drilling is so important, and understanding those first stabilization steps are key, because once you can stabilize and at least begin, I mean, someone who's receiving CPR obviously is not stable, but if you're ventilating and perfusing for them, at least you're preserving some ability to reverse what has ever happened to the patient. If
Mm-hmm.
you're not doing anything, like in this situation, if no respirations are being given, if no chest compressions are being done, then that pathway to death happens fairly quickly.
So they do start ACLS, and this goes on for 20 minutes in the patient's room. And then the OB decides it's time to move the patient to L&D because she's not responding. No conversations about resuscitative cesarean. I have no idea what the rationale is for moving the patient to labor and delivery because she's not responding. I mean, if she's not responding with being in place with the team working on her, there's no chance she's going to respond better by moving her somewhere. I mean, no chance. That's not going to happen. So don't move your patient.
Yes. I participated in a study where we used a fairly sophisticated mannequin looking at efficacy of chest compressions and ventilations in the mannequin. Obviously, we didn't do this on an actual patient, but the efficacy of both dropped dramatically during transport. It's almost impossible. I don't care if people were jumped on top of this mannequin, straddling, doing chest compressions. You just can't get the same coordination of compressions and ventilations and and actual adequacy of either when you are moving.
And then you're going to lose their IV because you're going to step on it literally. Because when you're doing this, somebody's literally straddling the patient on the gurney while you're trying to move, or they're running alongside, which is ridiculous. I mean, you're not getting anything
Yes.
doing it that way. I mean, it's just absurd to think that you can actually do anything effectively. And this relocation, remember, they're 3 floors away. So that means an elevator ride. Okay. So they move the patient to labor and delivery 26 minutes after the initiation of the code. The patient does not have return of spontaneous circulation. They get her on the operating room table and perform an ultrasound. There is no role for ultrasound assessment of the fetus in determining whether or not to perform a resuscitative cesarean. But it appears as if there was no consideration for a resuscitative cesarean because the presence of, they described as agonal fetal heart tones, is what prompted them to perform not an emergency cesarean under sterile field while CPR was continuing. So let's talk about how we do a resuscitative cesarean. The
Yeah.
goal is to start within 4 minutes of arrest, to be done by 5 minutes of arrest, to improve maternal circulation, improve chances of maternal resuscitation, while giving you your only hope of neonatal salvage. And the sooner you do the delivery, the more likely you are to have a good fetal outcome or neonatal outcome. That does not mean that you can get this accomplished within 5 minutes. Sometimes it simply cannot be done. And it's certainly not going to be accomplished if you are not practicing it extensively. It's never too late. Interestingly, in this case, 26 minutes after arrest, 31 minutes after the arrest, the baby was delivered. There was heart tones by ultrasound. So, it's not that you can't salvage a baby. It's just the longer you wait, the greater the likelihood you're going to have neurologic injury. Time is brain. Time is brain. So
Mm-hmm.
what are your thoughts on that, Julie? I know you have some.
Yeah, and I'm not smiling or laughing for any reason other out of frustration.
Yes.
It's a frustration response. For me, I began doing team training in maternal cardiac arrest in 2006, and I'm still kind of floored by the fact that there is not a clear understanding everywhere of what happens when a pregnant patient arrests. And I'm not quite sure. It seems like some practices just take off whether they're the appropriate practice or not, and for other practices you have to work and work and work and work to get people to understand what is the right thing to do. Everyone is definitely well intentioned. I completely believe that, but a it is such an anxiety provoking experience to know that you have this person's life in your hands. And depending on what you do, this person's either going to live or die. That is incredibly anxiety provoking. Then you have, on top of that, the fact that you don't ever do this. So that's why it's so important to practice. It's so important for there to be a clear understanding of what everyone's roles are. Because when you look at the whole picture, it becomes difficult. But when you break it down into little pieces, like for the OB, my role is to provide left uterine displacement and get ready to deliver the baby, which they do cesareans all the time. This is totally in their wheelhouse. They're totally comfortable with it. My role as a nurse is to either give medications. What am I going to give first? I'm going to give epi first. I'm going to give the whole thing. It's not like a neonate where you got to parse out little bits of it. Nope, you just give the whole thing. Follow it with a flush, hold the arm up, chest compressions. I'm going to do chest compressions. I'm going to do ventilation. So when you break it down into little parts, it's much easier to take on that one little part and do it well. And what happens when you start to train that way and when you understand what these little parts are is that the performance of the team dramatically improves. And when you're looking at hitting those parameters that the American Heart Association has set with getting on the chest right away, bearing the chest, making sure you have effective chest compressions, getting the rhythm analyzed in a couple minutes, getting the shock delivered if it's necessary, and giving epi within the first 5 minutes. Those are hard and fast parameters from the American Heart Association. You can begin to meet those parameters. I have seen OB nurses and OB units hit these parameters with
Mm-hmm.
the right training.
Mm-hmm. I think a lot of units don't even necessarily know these things exist because they may be hoping somebody's gonna come rescue them. But
Yeah,
as you preach and we've talked about so much, you have to be prepared to manage at minimum the first 5 minutes post-arrest and probably longer than that. The baby is likely gonna be out before your code team arrives.
right.
I mean, and
And
that's just facts.
I think being prepared, some part of it, of course, adding to the frustration and the chaos that can occur in these things is not having what you need. So I think a clear understanding is, what do you need at the bedside and what don't you need at where, and it may not even be a bedside, it could be the floor, as you well know, Stephanie. Basically, to do a resuscitative C-section, what do you need?
Yeah,
You need a scalpel.
that's it.
And looking at what we've done in other hospitals is just taking the placenta specimen container, putting a non sterile scalpel. This is not a sterile procedure. Put a non sterile scalpel, couple cord clamps, a blanket for the baby, a pair of scissors, bandage scissors, whatever. You've got your whole kit right there. It fits right in the bottom of most crash carts.
Mhm.
So that's everything you need to
Yep.
do that resuscitative C section. So if you keep a little kit like that in the bottom of your code cart, you can do a resuscitative C section anywhere you have a crash cart. And that's huge because in that med surge unit, where are they going to find a scalpel?
Yeah.
I mean, they would find all the other things, but you know, w- I think just making the whole process as easy as possible is what we should be doing, because it's such a difficult situation. You don't, any barriers that are there, you want to remove those barriers.
Yeah, and I think you were saying non-sterile scalpel, but I think what you meant to say was disposable.
Yeah,
So
disposable. Yeah, disposable. I
and
mean,
those
they
will be
are
sterile,
sterile,
but
but they are, yeah. But the
yeah,
whole
but
procedure is not sterile.
no, you do not need to splash anything on the belly. You do not need to prep the belly. This is not a sterile procedure. This is not a clean procedure. This is just a procedure. You are trying to improve your ability to resuscitate. You will deal with the consequences later if you get return of spontaneous circulation. You are not going to be worrying about infection control during this time.
Yeah, or anesthetic until
And
the patient wakes up.
yeah, you don't if you need anesthesia, you're not doing a resuscitative cesarean.
Exactly. Exactly.
So this is super important to practice. And this is if you have hospitalists, OB hospitalists on your units, they're likely going to be the ones responding and performing these procedures and they can be an integral part of your practice of this. I think one of the questions we get asked a lot is, well, what if we have an arrest and nobody can perform a cesarean? Well, then she's not going to get a cesarean.
Right.
That's
Right.
just, nurses are not going to do it. An ED doc's not
Mm-mm.
going to do it. If you're
Mm-mm.
not qualified to do the surgery, you're not going to do the surgery, period. And because you can't fix everything every time. But there were multiple opportunities here. Now, unfortunately, mom and baby did not survive this event, and they did perform an autopsy. And she was found to have severe bilateral acute pneumonia, intraalveolar hemorrhages, congestion and edema, and diffuse alveolar damage. This patient had pretty substantial pneumonia. I can't imagine that she didn't have pretty substantial respiratory changes on her assessments that just weren't performed significantly based on that. I mean, this patient died from respiratory failure, not she didn't die from pulmonary edema or a PE. This was pneumonia that killed this patient, unfortunately. And I don't know whether she was going to be saved or not. I mean, she may have, if she had lived, she
Right.
may have progressed. If she had not arrested, even if they'd done all the right things, she might have developed severe ARDS and been very, very ill. But I do think there were multiple opportunities here. This patient had multiple known risk factors to be high risk and for bad outcomes. Her age, her weight, her hypertensive disorders. She's
Mhm.
pregnant. She's a smoker. She has asthma. I mean, lots of things. The OB felt out of their league in managing pneumonia and really defaulted a lot to I don't know who. There were no consults on this patient. So no one else managed this patient. There was no, pulmonologist. There was no internal medicine. The hospitalist only became involved when the rapid response was called. So there was really inadequate assessment, inadequate monitoring. And when you're not assessing, you're not going to recognize the degree of the deterioration. It just goes on and on and on.
Yeah, and it it seems that whoever is going to be running resuscitations in your hospital needs to be aware of the difference during pregnancy. During pregnancy, you're going to be doing a major abdominal surgery if
Mhm.
if the patient is not responding. Now, certainly there's caveats to that. If the patient's only 2 or 3 weeks pregnant, or, you know, the pregnancy is not obviously not interfering with chest compressions, then there's going to be some decisions made about what's going to happen as far as the resuscitative C-section. It's probably not going to be done. But with pregnant women, particularly after that resuscitative C-section, you don't stop the
Mm-mm.
resuscitation, because
Right.
then you have an opportunity to bring that patient back. The other key feature that stands out to me about cardiac arrest in pregnancy is that the more common cardiac rhythms you're dealing with are pulsus electrical activity and asystole.
Mhm.
You say asystole to most code teams, and they're going to make the effort, but asystole just doesn't. When you go into asystole as an older adult, non-pregnant, you don't usually get a successful. Now, I'm not going to say they never get the patient back, but it's less successful. But in pregnancy, it's very successful. So if you've got the code team and your rhythm is asystole, you don't give up. You keep going to see if you can get this patient to reverse. So those facts need to be very apparent to anesthesiologists, to intensivists, to the code team in the hospital, so
Mhm.
that they understand and don't abandon the effort before they should.
Yeah. And because they have those PEA and asystole more commonly, those are not shockable rhythms, and so you're less likely to have to do a shock in a pregnant patient. So it's gonna be a little bit more straightforward, and less it can be and less intimidating, because that's kinda what intimidates the OB's teams a
Mhm.
lot, is having to give a shock, of course.
Yeah.
But I hope this has really helped people kind of think about, how would you handle having a patient that has to be off your unit? Maybe they're not in ICU, they're just on another unit. It doesn't mean that you have to have a plan in place. You can't ignore them, and you can't hope for the best. And that is physicians and nurses. Like, physicians have a responsibility in that too. If you're placing orders, you can't just assume it's going to get done. Communication is key. And if it doesn't get done, then you have to understand why and have those conversations, because if the systems are breaking, there's multiple opportunities for people to recognize that there's a problem that requires a change of plan or a change of care. So thanks everybody for listening to the podcast. You can keep learning with us at our CCOB Academy on our website, clinicalconceptsinob.com. Please help support our mission by joining us on our Patreon, patreon.com/CCOB. You can watch us on YouTube, and you can follow us on all our social media channels to stay connected. And thanks for listening.
Thanks.